Yeah, Renee, would you mind introducing yourself?
Sure. Renee Bolio Banks, Indigenakaj, Jaganashimang. So my birth name is Renee Bolio Banks. I'm an elder in residence at NACC. Been here for about 4 years, and it's really a great place to work. And I just love what we're doing with the community and just the compassion that comes from the people who work here. So it's really, we take good care of one another. So miigwech, have a good meeting.
Thank you. And then we'll introduce the rest of the group. Dr. Rabi?
Yes, hello, I'm Kari Rabi. I'm a family practice and addiction medicine physician here at NACC. And I've been here for about 10 years and I work in the NACC program.
Thank you, Michelle.
Hi, everybody. I'm Michelle. I am the nurse manager for the MAT MOUD program at NACC. Thanks for joining us.
Thank you, Tina.
My name is Tina Monnier. I'm the harm reduction manager here at NACC.
Nikki?
I'm Nikki Jardina. I'm the infectious disease nurse at NACC.
And I'm Lindsay King-Cooney. I'm the community and tribal engagement specialist at NACC. So that's our ECHO team. I'm gonna share my screen and we'll do some announcements to get started. So welcome to Midwest Tribal ECHO. This is our opioid use disorder education and treatment series. Today we'll be hearing about Xylazine from Audrey Segovia and Dr. Ryan Kelly. A little bit about the Native American Community Clinic, NACC. So NACC was established in 2003. We're an FQHC in the heart of South Minneapolis. We offer a wide variety of services from primary care. We have a MOUD program, behavioral health services, and traditional healing. We have jobs open at NACC. This is a list of the current positions open. If you go to the website down at the bottom, it's nacc-healthcare.org. You can read about the job descriptions there. Some session guidelines. So please know protected health information. If you could mute yourself if you're not speaking. If you could let us know who you are in the chat, your name, title, organization, and email address, then I can email you the post-evaluation survey as well. And if you're feeling up to it, if you could turn your camera on, we'd love to see your faces. And then some next echoes coming up. So next month we have Liz Velick talking about transactional sex. That's August 2nd. And then August 16th, Justin LeBou, the director from Avivo Village, will give an overview of that program. This is a list of a few other echoes that offer similar topics to us. We have Hennepin Healthcare, Indian Country Echo, and Stratus Health.
Muting the person.
We do offer continuing education credit as well. So if you do need the CME credit, please make sure you fill out the survey, which I will put into the chat and then email everyone as well. And then finally, case presentations. We welcome and encourage you if you have a difficult case or success story to share. It makes for a great discussion. My email address is listed at the bottom there, so feel free to email me with that if you have something to share. And then with that, I will hand it over to Audrey. Stop sharing. Thanks for being here, Audrey.
Yeah, thank you all so much for inviting us to do our presentation again. I am going to share my screen here. Okay. Great, hang on. Okay. So my name is Audrey. I'm a nurse with Hennepin County's Public Health, the Healthcare for the Homeless Project. I have been working as a nurse here for coming up on 3 years. And prior to coming here, I worked in St. Paul at the Healthcare for the Homeless, kind of with Dorothy Day, the Union Gospel Mission. So I was over there, and I've been working with unsheltered and unhoused people for, it'll be 10 years this summer, which is kind of wild. And then Ryan Kelly, he is a physician over at NACC. And he'll be joining us in a little bit if he hasn't been able to pop on yet, but I will get us started here. So a little bit about xylazine, some background. It was developed in the 60s as a potential blood pressure med. It's a similar chemical structure to clonidine, which is a antihypertensive drug that's used. It's actually also a med, the clonidine, used that sometimes for folks going through withdrawal and experiencing withdrawal symptoms. That being said, when this drug xylazine was in development, it was discontinued in human use because it was found to be so sedating. And so they actually shifted the development to veterinary medicine. It is not an opiate, it's a paralytic. And so it's used in veterinary medicine to sedate like large animals like deer, horses, for procedures. In the drug supply, it is being detected in fatal overdoses here in Minnesota. In 2022, it was found to be in 34 fatal overdose cases in Minnesota. You'll often hear it referred to as trank or trank dope. And we first kind of started hearing about it being cut with fentanyl and heroin back in the early 2000s in Puerto Rico. We were hearing a lot about trank dope and kind of the associated wounds that were popping up and looking very scary. The thing about xylazine is that it's not regulated by the FDA because it is not, so it's not considered controlled because it's being used in animals. So it's not human grade. So it's easy to get online. So people are able to purchase it online to cut. And it's kind of at the middle person level, right? Like it's not like the larger suppliers. It's kind of like the local regional area of the chain where the xylazine is actually being cut with the drugs. So it's inexpensive. It's pretty easy to get. And the reason it's being cut is it's supposed to be kind of giving fentanyl or like opiates legs, right? And like kind of prolonging this euphoric like high effect is the rationale, right? And recently, so we all are familiar with kind of fentanyl test strips and the availability of those. Recently, xylazine test strips have become available. They're still, they're relatively more expensive than fentanyl test strips. They're about $2.50 per strip or so. So you can buy a pack of 100, but it's like to keep in your clinic, but it's like about $250 or so to keep on hand. And there still is like the reliability is still not like fully determined. It's not a quantitative measurement of like how much xylazine is in a sample. It's just qualitative. So it's a yes, no, is it there? Okay, so dangers of xylazine in the supply.
And Audrey, I'm here if I can jump on.
Great.
Yeah.
All right, go ahead.
Cool. Hey, everyone. So again, I'm Ryan Kelly. A lot of my mentors are on this call. I'm a primary care doc at NACC Clinic, the Community University Healthcare Center, where I see adults and kids. I'm a hospital medicine doc at the University of Minnesota Medical Center, and am a part of the NACC Suboxone program. And after a lot of mentorship in harm reduction, et cetera, now I'm director of a harm reduction focused hospital medicine consult team at the University of Minnesota. And just as a quick plug of, fear for the people we care about, on my drive into clinic today, I haven't been at clinic for a week, just seeing all the new fencing up along Bloomington, and just, Minneapolis is quickly becoming a land of the fenced to prevent people who are unhoused from sleeping. And so we'll kind of talk about that at the ends. But talking about the dangers of the xylazine and the supply, first, risk of overdose. Xylazine's not an opioid. And so people will say, well, so hence it doesn't respond to naloxone. So most importantly, remember, most xylazine use occurs with opioids. And so if someone isn't moving, isn't breathing, and you decide that they need naloxone, give naloxone. Now, if they're breathing, and this is tricky, if someone's not waking up, traditionally, are people really looking for someone being blue, or just they're not waking up, they're giving naloxone? Well, if someone is overdosed from xylazine, they may still be breathing. but they could be out for a long, long time. And so that means if someone's in the same position, they could be cutting off blood supply. I actually, over the past few years, I have had more patients come in with different, what we call neuropathies. So someone falls asleep with their arm like this, they pinch the nerve, and then they can't move their arm, and it takes weeks for that to recover. In extreme heat, which is a challenge right now across the country, or extreme cold, that can be a huge issue. It also makes people vulnerable to assault. Again, the plug, if someone's not breathing, give them naloxone. If you're worried about an overdose, give naloxone, because xylazine is often mixed with opioids. Making sure afterwards that if someone is breathing but not waking up, that they're in the recovery position, and sometimes need to be moved around. So again, this is meaning people who are out in the community need to have a little bit more education on how to manage someone once they get them breathing again, because they don't just get up and start walking away. I'll turn it over to Audrey for risks about skin ulcers.
Okay. So folks have probably heard a bit about xylazine related wounds. It's been kind of in the media, right? I feel like a bunch of papers have kind of picked it up and then dubbing them these like zombie wounds. But a wound is a wound, right? Like the way we take care of them is not going to change a ton just because it's related to xylazine. So a little bit of info and just background on what these like ulcerations are looking like. So people are finding them mostly on their extremities. So arms, calves, ankles. They can appear either at like kind of in relative proximity to like the injection site of where someone may be injecting, or like a distant site wound. And this is something that we're even seeing in folks who are not necessarily injecting, or maybe smoking their drugs, are still having these xylazine-induced skin ulcers. And these distant wounds are happening kind of spots that are kind of odd, like on someone's back, like someone's not injecting into their back, even happening on the face, in the nostrils. So kind of odd, not super sure of like the rationale of, or like the etiology of like these like distant wounds that are developing in folks. But yeah, that is kind of like the big gist of it. And there's the two types. There's the injection site wounds and the distant site wounds. They both kind of start similarly. They kind of start as a small blister, so a little bit of a bubble on the skin that will open and kind of start to widen and deepen. And I do have some pictures on the next slide. One thing that's been really common to see is kind of this dime-shaped morphology. So they're small, like basically start out kind of looking like a blister about the size of a dime, and then it'll kind of pop and open and widen, deepen. These wounds, they need to be cared for like any kind of open wound. They don't necessarily require antibiotic treatment if there's no like clinical signs and symptoms of infection, right? So just because someone has what you think might be a xylazine related wound, you still want to be looking and assessing the wound for infection. So looking for like redness at the wound, say, like induration, if the patient's been having fevers, any kind of purulent drainage, like that's going to be much more indicative of whether someone needs a course of antibiotics versus just like the assumption of like, ooh, this looks scary, and there's like a bunch of like non-viable tissue here. Let's throw an antibiotic at it. And so really to assess it, you need to make sure that you're actually visualizing the wound bed and like seeing if there are like those signs and symptoms of infection. The biggest thing with all wounds, right, is we need to be maintaining a moist wound bed, keeping it clean, and encouraging regular dressing changes. That doesn't mean someone needs to be coming into clinic like every day. Like send folks out with a goodie bag of supplies, right? Like, and we know people, if they don't necessarily have kind of like clinic grade supplies, they're going to make do and find a way to care for their own wounds, but just trying to really emphasize doing the best they can to keep it clean, keep it relatively moist, so to promote healing, and ideally keeping it covered are going to be really huge concepts that we can give to people to just keep them safe and keep it from spiraling into something larger. So here are some of the things that, some of the wounds that I had mentioned. So you can kind of see, this is pulled from a webinar that was really great through Surge out of Philadelphia. But you can see the dime-shaped morphologies like in these, in some of the distant site wounds. So in the upper left, you see like a few of those kind of punch out areas. That's kind of like really textbook for the xylazine. You can see the deepening of the ulceration on the bottom left, and then the distant site wound. Sometimes these wounds will require like a person to go into the hospital for like a surgical kind of debridement, like this gentleman who has like the blackening of his skin, the eschar on his wound on his arm. So like that needed to be like surgically debrided for that person to progress. But like once that's done with regular wound care, like these wounds will heal. They don't need to be big, bad, scary. Like the sooner that we're able to kind of engage with people about their wounds, kind of educate them about looking at their kind of assessing their skin and trying to be mindful that these can grow pretty quickly is going to be an important thing. So, but these are all things that can heal with like proper regular wound care. Kind of here regionally, we have clinics that are able to take care of folks like on a walk-in kind of basis for wound care. We've got the Endeavors Clinic, which is part of Healthcare for the Homeless. We've got the COLA Clinic, which is like a little outreach clinic. They've got an excellent nurse there on Wednesday afternoons, Molly, who does wounds are her bread and butter. I've got Southside and NACC listed on there. You guys have walk-in hours for folks to be seen, and there's also Healthcare for the Homeless in St. Paul. All folks in places who are really knowledgeable and familiar with working with the population we serve, and also working with wounds and making sure people have access to what they need.
All right, so I'm going to transition, talk a little bit about withdrawal from xylazine. And, so far we've talked about the dangers of overdose. We've talked about wounds, which again, the pathophysiology is still not greatly understood. On the one hand, withdrawal makes, physiologically, pharmacologically, we understand a little bit better, but everything I'm about to say comes with a caveat that I am not seeing patients in the hospital who are saying I'm withdrawing from xylazine. I'm not seeing people in clinic that say I'm withdrawing from xylazine. Now, maybe people are withdrawing, but if we don't have the right testing and people don't have the right education on knowing what they're using, it makes treating the fallout even more challenging. We'll talk about that again in a moment. But xylazine withdrawal, so it may be super, super intense. And there's some anecdotal successful management of xylazine in and outside the hospital with clonidine, and I'll talk about that in more details in a moment, or when people are in the hospital with ketamine. So ketamine, you can get orally, but usually ketamine is, when we're talking about that, we're talking about someone like in the intensive care unit getting IV ketamine. So going to the next slide. So what we've seen, this comes out of Philadelphia. So again, xylazine is a paralytic agent, but it acts on the alpha-2 adrenergic receptors, just like clonidine. Clonidine is a weak blood pressure medicine, but we often use that for anxiety. We'll use that for opioid withdrawal as kind of a supplement to starting Suboxone or methadone, or just in between use. Clonidine itself is a weak blood pressure medicine, though. So a side effect is it can make the blood pressure go down. And so it can make someone sleepy. But this here is dosing the 0.1 every 6 to 8 hours scheduled is what we used in Philadelphia. But again, I have not talked to anyone who has personally had clonidine to help xylazine withdrawal. I'm really looking forward to question and answer at the end of this to see what other experiences people have. Making sure, again, the fact that usually if someone's using xylazine, it's with an opioid. So people may be interested in buprenorphine or methadone. We don't have time today, but the strategy for starting buprenorphine with fentanyl is kind of changing. Using gabapentin. And then, like I said, IV ketamine can be done in the emergency department or the ICU. All right, moving on to our next slide. Other issues. So, lack of education within healthcare, wounds not being cared for properly. I had a patient who, she's a methadone patient, but was using fentanyl on top of it. One day of the week, I had a conversation with this person about Xylazine. They'd never heard of it. I couldn't tell them, is it more likely in powdered opioids or compressed pills? I'm not sure. The very next day, she had messaged us at clinic saying my toe is really hurting. They came into clinic. This person has diabetes. It really looked like their first acute gout flare of their big toe. I got another clinician to take a look and they agreed it looked like gout. So we started treating it with a gout. Within 3 days, this person's in the hospital with a wound on top of their toe. And it was diagnosed as a diabetic foot ulcer. They did an exploratory surgery and everything was necrotic on the foot. So definitely fentanyl was likely. This is not a diabetic foot wound. This is not gout. But when she discharged, it was still called a diabetic foot wound. Hospitals, it took hospitals forever to catch up with fentanyl. They're still trying to catch up. And now Xylazine is there. I know Hennepin County Medical Center can test for Xylazine. I'm not sure how quickly it comes back. At the university, it's a send out, takes 9 days. Most people don't even know that the order exists. So very difficult to educate individuals about their use. I think Audrey may talk about Xylazine test strips in a moment. And so or in more detail, but Audrey mentioned the cost. The other challenge with the test strips is people currently have to use their own drug. They can't use residual left in their syringe or their cooker. And so will people test when they have to waste their own drug is an important question to ask. Hugely in healthcare, pain and withdrawal aren't being managed well. It leads people to leaving hospitals before they're medically ready. And I think now I'll turn it over to Audrey.
Alrighty, so got a list here for people to kind of peruse of just interventions that are needed really badly. All of these are super ideal, right? Like this would be a wonderful golden ticket, but some of them are things we can really apply and like throw into our practice. We all know people having housing and stable housing greatly improves their health outcomes, right? There's paperwork that can be associated with housing that we can do and help people with. So just kind of familiarizing yourself with that and helping folks out with that paperwork, wonderful. Okay, access to running water, dressing supplies, gloves. That is something that we can partially address if we're working with someone who is staying in an encampment or staying somewhere without running water, right? We can load them up with dressing supplies, gloves. We can give them hand sanitizer. We can give them bottles of water or like saline as needed if they need to be cleansing their wounds, and just kind of continue to invite them to keep engaging in care, right? So that's like something that we need to assess for as clinicians, right? Like we need to have that knowledge of where folks are staying and what their accesses to these supplies are. Mobile wound care can be great. It's really hard to get the money and the dollars to be able to do that for our people, but mobile wound care can be great to just be able to track the progression of the healing for a person's wound. This kind of depends on your EMR, but if you're able to upload pictures to a patient's chart of what their wound looks like, that can be hugely helpful, especially if you have kind of intermittent and sporadic staffing in terms of like who is in clinic routinely, because not everyone knows how to like necessarily accurately measure a wound. So being able to like visualize what it looked like a week ago versus what it's looking like in front of you today can be so helpful. And then also just educating people about their wounds, how to care for them, when to come back in, like when they really should be going to the hospital because things are getting a little hairy. That can be really important, especially a lot of our people, they care for each other as well. So if they know of folks who have wounds, they can really encourage them to be engaging in care or hopefully educating their friends, relatives about just like safer wound care and safer use. Ideally, like drug checking would be nice, but kind of there are those barriers to drug checking with the xylazine test strips. Like they're not super cost effective, and is someone really going to buy drugs just to test to be sure? Yeah. Let's see here. Some strategies that we can talk to people about is people checking their drugs, potentially changing suppliers, or like their drug of use if they currently have a wound that we're working on healing. You could support a transition to smoking versus injecting, but there still is that risk of like a distant site wound related to xylazine. Again, like educating on self wound care and when to seek emergent care is like so huge. Let me see. And then also just making sure folks know about like the community programs, like the syringe exchange programs, like the calendar, where people are available, when, like those are great ways for people to connect and engage, and potentially have their care like escalated or addressed by like another outreach worker who could connect with them in the community. Oh, another thing too, so since xylazine is a paralytic, providing the education that it is a paralytic. So when someone is using, just being mindful of kind of their body positioning so that they aren't necessarily putting themselves at an increased risk of injury related to being like super sedated and compressing like nerves on one part of their body, kind of like Ryan mentioned, like kind of losing that range of motion and feeling and strength because of like that nerve compression. Also too, so like one way wounds develop is like because of not adequate blood flow. So like blood, nutrients, and oxygen making its way to the skin. And that is often caused because of compression. So just making sure people understand it's a paralytic and that it could be causing compression, which can really affect their skin integrity, is going to be important. This is just like a quick thing about the xylazine test strips, just kind of what they look like, what the testing procedure is. This is just pulled from the medical supplier website. This is a copy of like the syringe exchange calendar in the Twin Cities right now. I don't know, Ryan, if you wanted to say anything more about that, but otherwise we are kind of ready to move on to questions, I think.
I think Mark asked a great question. Do the drug dealers know that the products contain xylazine? That's one of the big challenges, trying to find out where is xylazine getting cut in. If we had a better grasp of where it's getting cut in and what the products looked like, I think we'd be able to provide better education. I am still not sure. Is it in powdered opioid more likely than compressed tablets? It's been very hard to figure that out. So to answer your question, do drug dealers know? I don't know. Does anyone else have an answer to that? While people are all thinking about percolating on that one, I think, oh, go ahead.
Oh, sorry. It looks like there's a comment. Miranda commented, I heard from users that yes, they want it.
And Audrey, I'm not sure what you're saying, but from what I'm hearing from, Sarah Jane and others, both, on the ground here in Minneapolis, but also across the country, is that for some people, the challenge with fentanyl is it wears off so quickly. And once the positive effects wear off, before opioid withdrawal kicks in, you're filled with anxiety. So if you can take anything that allows the positive feeling last longer, well, that could be a good thing. And so I think there are some people that, actively would seek out xylazine because at the right dose, it makes the positive effects last longer.
Yeah, and I mean, as long as folks kind of know what I feel like the biggest thing, right, is like you don't want like the buy one thing, think you're getting another, right? Like the people just need to know kind of what they are actually like using. Just so that they kind of know what to look out for, right?
We're not muted.
Looks like there's another comment. Is it inevitable that xylazine will be contaminating our entire supply?
Yeah, Shay, great question. I think, fentanyl is a product of the war on drugs, right? When we are cracking down on heroin and it's easier to make it, that's not what the cartels do. And so, is there even heroin? I'm not sure. So is xylazine going to contaminate the entire supply? I really don't know. And I don't think we have a great grasp of how much is out there and where. But I do know that in other parts of the world, I just had a friend that was in Portugal at their safe use sites touring them. They don't have fentanyl, let alone they don't have xylazine. That's because they don't have the same punitive war on drugs process in a lot of European countries. I'm curious, is anyone out there, again, the biggest challenge I have as, these days, most of my practice is either within the walls of a hospital or within the walls of a clinic. So if someone doesn't have the luxury to, or the resources to make it to clinic, and then in the hospital, we don't have the right tests. I don't know if I'm treating people with xylazine withdrawal. Does anyone have any experiences where they've had someone that was pretty confident they went through xylazine withdrawal and tried a medication that helped them feel better?
There's a comment.
Yeah.
Let's see, so Haley has a comment on that. What I'm hearing from law enforcement is that it is being added further down the supply chain. Not sure if dealers necessarily know it's there or not, but at this time it's not coming across the border in the fentanyl supply typically.
Mhm.
I haven't encountered any patients who are familiar with it, which I think has been really interesting.
And we've had some wounds that have been suspicious for it, but we haven't been able to have any confirmation.
Right. Are you able to stop sharing? And then we can all kind of
CJ.
See
each other?
faces more
Yeah.
clearly. I guess I'm curious. So I guess, fentanyl being in the supply makes sense to me from a business standpoint. Like I understand, I guess, why they've added that and it's cheaper and it, all of these things. I guess the rationale for adding xylazine, I think, would maybe help us understand and pinpoint where it's being added. And it does make sense that it would be added kind of further down the line because it maybe decreases the frequency of use. So it doesn't make sense that the dealers, and the cartel would want that added in there, right? They want people to use more often. So it doesn't make sense that they would be adding it because it helps people to use less often.
I really like that train of thought, Michelle. I think on the flip side though, is if you've got the good stuff, people will buy from you. Right.
Fair.
Yeah. So, and my perception of fentanyl, the way I kind of heard about it, is that, it was kind of like people with resources who was using the dark web and kind of, cutting in their own supply and then trading. And then higher up distributors found out, so they were getting their, their kilo of heroin delivered from, snuck through the border, mostly likely from Mexico. We're cutting in fentanyl and distributing it, and it took a while before cartels actually figured out why are we growing poppies. That's kind of the very brief. Does that seem kind of what other people's knowledge are? Michelle, you're nodding, right?
Yeah.
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 And so that's the question with xylazine, how, if the demand goes up, then maybe we'll see more of it.
I really, what can we do to kind of speed up the process of testing? So I feel like, it took a long time for us to get access to fentanyl test strips, to be testing, are you urine drug screening for fentanyl, things like that. So what can we as regular people do to help speed up that process so we can get access to testing so that we can better learn how to treat patients and help them?
I mean, my plug would be, so I'm going to pop this in the chat in a moment. The Opioid Safety and Naloxone Network is a nationwide Google group that hopefully some of you guys are on. This is my go-to for, hey, I need help to get international input on things. And so DanceSafe is a company that's working on test strips as we speak. Are you guys familiar with OSNN?
Yeah.
Okay.
Yeah.
And got it. Should I try and, as I'm talking, pop something in the chat so other people can follow the link? Tina, are you talking to us? Okay.
Yeah, whatever you've got, if you want to post it in the chat, that would be great.
Cool.
Yeah, and I think that people, I don't know if this was what you were going to post in the chat, but I think people would be interested in joining OSIN if they had the opportunity. So I think if you have that, it's like a Google group that.
Yep. So I just
request.
popped in the chat, and so so you can follow this link. Now the key is they don't accept requests from law enforcement or journalists, media, or industry. And so when you click it and apply to it, you have to give a quick one-liner about why you're interested. The other thing, the university blocks Google Groups, so I had to use a different Gmail account. But this was 2018 when folks on the ground were saying Suboxone wasn't working. That's where we first found out about fentanyl and how fentanyl was different with Suboxone. So just as an example.
Thank you. There's another question in the chat from Mandy. Interested in hearing about Xylazine used like a date rape drug. Are people seeing this in their EDs?
I'd be curious, are people who are, yeah, the challenge is in the EDs, I think the question would be, are they seeing more people reporting sexual trauma, right? The people most likely to be traumatized sexually have already faced healthcare induced trauma. And so are they going to the ED? And so I'm curious, I'm curious from Sue Purchase or for Southside Harm Reduction, are they hearing participants talking about it? Because I bet you that's where it'd be reported first. Because the challenge, if someone goes to the ED and does report being traumatized, will they do the right testing to find out what's in their system?
Looks like there's another comment from Andrew. I've done over 1,000 fentanyl inductions with Suboxone, 0 issues, doses up to 24 milligrams needed.
I'd be curious, Andrew, are you having people wait until opioid withdrawal? Are you giving them a dose of giving them 8 Suboxone, and if they feel worse, having them take 16 immediately? Are you doing kind of the Bernese method where they cut their films into tiny pieces and use their opioid for a few days? How do you do it?
It looks like responding in the chat. So
Gotcha, sir.
Can you come on audio? Yes, you can come on audio.
yeah, come on.
So I'm boarded in 3 specialties. I've worked with the Poison Center since 1997. And so I don't want to be argumentative, but I've been a toxicologist and I've seen the DEA headliners come out on crocodile, how it's going to kill everyone, and it's the most fatal drug ever. And on this new drug and on that new drug, xylazine is really a cousin of clonidine. And so one thing, I've been treating fentanyl overdoses since the 90s in physicians and attorneys. And, you know, and then later on the street, I mean, a lot of doctors, when they go astray, they, and I've been asked to investigate fentanyl deaths in hospitals. But there's a lot of misinformation that comes out of the DEA, and I don't know if it's intentional or not, or if they're misadvised. I mean, imagine that marijuana is a Schedule I for being highly addictive and no medical use, and fentanyl is a Schedule II. Does that make sense to anyone? But that being said, xylazine is very much like clonidine. It's an alpha-2 agonist. I have vet friends, they use it to sedate cows. And so alpha-2 agonism suppresses your sympathetic nervous system by...
We interrupt him.
Sorry?
Well, we have already, so the session started at noon and we did kind of go through all of this information already.
Okay, I'm sorry. And I didn't want to cause a stir, but I'm just saying, so I've been working with tribal entities for the last 7 years. I've had, we have over 450 patients. I've done at least 1,000 inductions. Many people had xylazine. We don't even bother testing for it. Almost everyone's on fentanyl and or other things. I've had no issues. I feel like it's misinformation. I've
Sorry,
been hearing
can you be clear? You've had no issues with, because the harms that the presenters were talking about were related to like pressure injuries related to being unconscious for long amounts of time, or so like when you say no issues, I guess what are
So one, I've never seen a clonidine death, and and clonidine and xylazine are cousins, and I've seen massive overdoses of clonidine in kids and adults. Could a high dose of xylazine kill someone? Yeah, but it's way less toxic than fentanyl that can kill people willy-nilly. I mean, fentanyl is really good at breathing cessation. So the xylazine's in there because drug sellers want to make more money. One thing that really disturbs people is they reverse people with Narcan, and the people are still confused because a lot of times the xylazine will cause sedation. And so they're like, why isn't this reversing? Now, any drug that makes people...
Yeah, Dr. Toplip, I think the biggest concern with the xylazine is the wounds that it has been causing in the patients that we've been serving. We kind of, our presenters went through the whole presentation. And they explained that it was really, you know, a relative of clonidine and those things.
Good.
Yeah.
So the wounds you see in any sedating drug, I see them in phenobarbital overdoses. I've seen them in many different kinds, like methadone overdoses. Like, if the wounds are related to pressure sores, or are you talking about at injection sites?
Both.
But injection sites, you realize that xylazine will just be one constituent of many. Things can include talcum powder, sodium hydroxide, all kinds of things. So I don't think that it makes sense.
But they're also talking about the wounds that they're seeing that are just related to ischemia. And so, and we've seen that coming to our clinic. So, you know, and I think that other drugs may cause those same wounds, but the reason that we're focusing on, we're not saying nothing else causes it, but I think the reason we're focusing on this today is because xylazine is now very common in the fentanyl supply, and we're all serving people who are using fentanyl regularly. And so it's just an ongoing issue for our patients.
So it's likely that xylazine can cause significant hypotension, just like clonidine does. It has some backdoors for minimal opioid effect, probably by causing endorphin release, but it has no effect on opioid receptors itself, zero. So you could get pressure sores. You might get an exacerbation of the pressure sores because there's hypotension on top of it, so those areas aren't perfusing well. But I can think of no evidence that xylazine itself would cause injection injuries, because that's the way that veterinarians use it in animals. They inject xylazine directly into tissue without issue. The other thing is that there's many other things in there besides fentanyl and xylazine. You know, this is a non-pharmaceutical grade product that people are selling. And I've just been hearing a lot of people say like with a new fentanyl, you have to use methadone. Absolutely not. I've proven that untrue today and many days over the last 7 years. So I'm not sure where that's coming from. I think it's a timing issue and a dose issue.
Yeah, so thank you so much. Thank you so much, Dr. Toplap. We appreciate your comments. We are going to move on to the next comment. Just so that thank you. We appreciate your experience as a toxicologist. Does anybody know after August 1st, will that change the resources we have available for our folks who use drugs? Anyone able to distribute xylazine strip smoking supplies on a wider scale than now?
Good question.
Such an important question. I wonder if someone from Southside or yeah, I mean, you know, NACC as well. The kook is we're not at the moment. We're not allowed to distribute syringes because we have federal funding. But yes, the new law is going to drastically improve resources. We hope in more grants, etc. Anyone else able to talk in more detail about that? Tina, are you talking to us?
So I know, okay, so smoking supplies, the paraphernalia, the new paraphernalia laws should make smoking supplies and glassware more allowable. And I don't know, I'm not an expert on this. And there are monthly meetings. This like coalition is working on all of this, and they're also working on educating people like us on how to talk about this. So if anyone wants to be a part of that monthly meeting group, just put a note in the chat. Awesome, yeah. And then yeah, distributing xylazine test strips. So my understanding at this point is that with the current funding that I have, I'm not allowed to buy those test strips because of FDA approval. However, so yeah, and I'm not really sure how the new legislation will impact that. I'm just not really sure. I know people are buying xylazine test strips now. I think Southside has some. I'm not sure what funding they're using. And yeah, we are working on trying to find a way to buy them. So yeah, it's not super great answer, but that's what I know.
Kim says it will be okay to dispense, however, grants may take a while.
Pam commented it has been
Avivo has them too. Yeah.
decriminalized effective August 1st, along with syringes and residue in syringes. And we are planning to have an echo on this law.
Oh
as
yeah,
well as-
Eddie Krumpetich.
Yeah, later on this year. So we'll keep you posted on that. Do you have any final thoughts or questions? Brian and Audrey, is it okay to send out your slides from today to people that are interested? Cool.
Definitely okay with me. Yep.
Okay, thank you. So I'll make sure to do that along with, I'll send out our YouTube page information because you can view all of our echo recordings on our YouTube page, as well as the post-evaluation survey link for people that would like to fill that out and need CME credits. So
just a one parting comment, as we're talking about places for wound care, people who are outside the Twin Cities, or in the Twin Cities. You know, I work at Kook. Kook is just, unfortunately, we have some nurses who have some wound care, we have some supplies, but a lot of primary care clinics aren't currently designed for walk-in care, which is a big barrier. That's why I didn't put Kook directly on that list. We do walk-ins, we have some, but we're not as easy to access as some other places at the seconds. And I think that's the same problem with a lot of primary care clinics around the state. And to Shay's point of, would be great if we had an active building of this list. I know we've got some Duluth representation here today. So it'd be one thing maybe that we could follow up on afterwards.
That's a good idea.
Yeah, I like that.
Cool. All right. Well, I'm going to drop, guys. Thank you so much.
Everybody.
Thank you so much.
Thank you so much.
Everybody. Please join us
Bye.
next ECHO, August 2nd, transactional sex. Thanks for joining. Have a good day.